If you're on a Medicare Advantage plan, don't assume it's automatically renewing the same way it always has. This fall, plan choices are shrinking. Deductibles are climbing on the plans that remain. And your maximum financial exposure if you get seriously sick, the number that actually protects you, depends more than ever on the type of plan you're in. This isn't a maybe. The window to fix any of it opens October 15th and closes December 7th, whether you're paying attention or not. CMS has already confirmed standalone drug plans are shrinking by over 20% this year, with some carriers exiting entire states. CMS has also finalized the numbers for 2026, the maximum drug deductible, and the real out-of-pocket limits you'll actually face, depending on your plan type. In the next few minutes, I'm walking you through exactly what's changed and what to check before December 7th. Change 1 is about a 6-week window that doesn't wait for you. Change 2 is about plans disappearing out from under people who did nothing wrong. But Change 4 connects directly to a program some of you signed up for this July. And this fall is when you find out if it keeps working for you into next year. Chapter 1, the 6-week window. Let's start with the calendar, because this is where people lose their options without realizing it. The Medicare annual enrollment period runs October 15th through December 7th, 2026. Changes made during that window take effect January 1st, 2027. This is different from the enrollment period in January through March. That one only applies if you already have Medicare Advantage, and it only allows one change. The fall window is the real one, switching between original Medicare and Medicare Advantage, changing your drug plan or dropping coverage entirely. Miss it, and in most cases, you're locked into whatever you have for a full year. Here's the part that catches people off guard, even when they're paying attention. If you do nothing, you get automatically re-enrolled in your current plan for 2027, even if that plan has quietly raised its costs or changed what it covers. Every plan is required to send an annual notice of change before the window opens. That document is the only place that tells you what's actually different about your specific plan for next year. What you should do, mark October 15th and December 7th as hard deadlines, not reminders. Find your annual notice of change and read it, before assuming your plan is the same as last year. You might be thinking, I like my plan, I'm not touching it. Fair, but here's what's actually true this year. Liking your plan might mean liking a plan that isn't offered in your area anymore come January. That's not a scare tactic. That's happening in counties across the country right now. Chapter 2, the disappearing plan problem. Insurance companies aren't required to keep offering the same plans forever. Every year, some pull out of counties, exit states, or discontinue specific plans. This year, that's happening at a larger scale. Standalone Part D drug plans are down roughly 22% compared to last year. Some carriers have exited certain markets completely. Here's the part worth understanding clearly. You can do everything right, read your notice, decide you're happy, plan to do nothing, and still end up needing to act simply because the plan you were happy with isn't being offered anymore. If that happens, Medicare does give you a safety net. If your plan is discontinued, you get a notice and a special enrollment period running December 8th through the end of February to pick something new. But that's a scramble window, not a comparison window. You're choosing from what's left under time pressure instead of comparing calmly during the fall window when your options are widest. There's also a newer protection worth knowing, but it comes with a real condition, so listen carefully. If you enrolled in your Medicare Advantage plan by using the Medicare Plan Finder tool on Medicare, Gov, and within 3 months discover a doctor was listed incorrectly in that plan's network, you get a one-time opportunity to switch plans or return to original Medicare. This only applies if you actually enrolled through Plan Finder, not if you signed up through an insurer's website, a broker, or a printed directory. And it's only available for 2026 plan year enrollments. If you qualify, call 1-800-MEDICARE directly. What you should do, don't wait for a termination letter. During the fall window, actively confirm your plan is still being offered in your area for 2027. If a specific doctor or specialist matters to you, verify they're still in network before enrolling anywhere. You might be thinking, okay, my plan's still around, so I'm fine. Maybe, but a lot of plans that are still around got quietly more expensive, even when the premium on paper looks unchanged. Chapter 3, the Vanishing $0 deductible. For years, plenty of Medicare Advantage drug plans came with a $0 deductible. You paid your copay from day one. No deductible to clear first. That's been shrinking for consecutive years, and fewer plans offered it this year in 2026. Meanwhile, the maximum allowed drug deductible already hit $615 in 2026, establishing a new, higher baseline confirmed by CMS. So as you look at your 2027 options, if your plan didn't have a deductible before and does now, that's real money out of pocket before your coverage even kicks in, on the exact same plan name you've had for years. Here's why this hits differently depending on your situation. If you're managing a chronic condition with regular prescriptions, a new deductible might barely register, because the annual drug cost cap protects you once you've spent enough for the year. But if you take one or two medications occasionally, and you are specifically relying on that $0 deductible because your drug costs are otherwise low, a new deductible can raise your yearly spending proportionally more than it does for someone on expensive, ongoing medications. What you should do, don't compare plans by premium alone. Check the deductible specifically. If your plan added one or raised it, calculate what you actually spent on prescriptions last year and see whether a different plan leaves you better off. You might be thinking you've checked the big stuff already. Here's what most people miss, though. The number that protects you if you get seriously sick depends heavily on which type of Medicare Advantage plan you're in, not just which company sells it. That's a detail almost nobody checks before enrolling. Chapter 4. Out-of-pocket limits and the GLP-1 connection. Every Medicare Advantage plan has a maximum out-of-pocket limit, the most you'll pay in a year before the plan covers everything. It's your safety net. In 2026, the average out-of-pocket limit for in-network care hit $5,421. If your plan also covered out-of-network services, that combined limit averaged $9,825. Those are the baselines you are comparing your new 2027 plan against, and here's the detail that actually matters when comparing them. PPO plans average a noticeably higher limit, $6,592, compared to $4,636 for HMO plans. That's nearly a $2,000 gap in your worst-case exposure, built into the plan type itself, before you even look at which company sells it. If you're managing something chronic with regular specialist visits, an HMO's lower limit might protect you better, even with a smaller network, because you're more likely to reach that ceiling in a difficult year. If you travel or split time between states or want the freedom to see specialists without a referral, a PPO might make sense anyway. Just know you're accepting a higher worst-case number for that flexibility. Here's where this connects to July. If you got onto the new Medicare GLP-1 Bridge program this year, the $50 a month coverage for weight loss GLP-1 medications, you need to know the actual rules for 2027. The bridge runs through December 31st, 2027, and it operates completely outside of your standard Part D insurance company. That means you are free to switch drug plans this fall without losing your bridge access. But there is a catch. To stay on the bridge, you must remain enrolled in a Part D plan. And if your health changes next year, say you are diagnosed with type 2 diabetes or sleep apnea, you will be disqualified from the bridge and forced to use your standard plan's coverage. That makes choosing a plan with a good formulary this fall critical, just in case you need it as a fallback. What you should do? Weigh PPO versus HMO based on your actual health needs, not just habit. And if you're on the GLP-1 Bridge, shop for your 2027 plan as if the bridge might disappear. Because if your health status changes, your standard coverage is all you'll have left. The stack why these 4 changes compound. None of these sit in isolation. Miss the 6-week window and you're locked in for a year, good or bad. Assume your plan still exists and you might get blindsided by a termination notice in December, scrambling instead of choosing calmly. Ignore the deductible shift and you could pay more out of pocket on the same plan name. Overlook the difference between PPO and HMO worst-case exposure, and you might be carrying more risk than you realize, especially if you're also tracking something like the GLP-1 Bridge. None of these 4 is catastrophic alone. Together, they're the difference between a manageable year and a genuinely difficult one financially, and every piece of it was addressable, with one afternoon of attention, before December 7th. Getting your Medicare Advantage coverage right this fall protects your health costs for next year. But coverage is only one part of your year-end money picture. The same weeks you're reviewing plans, other deadlines and decisions are quietly stacking up too. The kind most people don't think about until it's too late to act on them. I'll be covering more of those in an upcoming video, so keep an eye out, because getting Medicare right and stopping there is still only part of the job.